welcome to another instalment in the Insight APSAD webinar series. It's nice to be back. We've had a few weeks that have been interrupted with public holidays and short weeks, but it's nice to be back and here today welcoming today's presenter. Firstly, though, I would acknowledge the traditional custodians and owners from across Australia and from the lands in particular of the Turrbal and the Yuggera people, where we here at Insight are based. It is their continuing connection to the land, water, culture and community, their knowledge and teachings passed down from generation to generation that informs the work that we do and the ways that we do it. We pay our respects to elders past and present and to those listening today, wherever you may be from. I now have the pleasure of introducing today's presenter, Dr. Llew Mills. Dr. Llew is a drug and alcohol researcher with the University of Sydney Medical School. He's also a statistical consultant for the Drug and Alcohol Clinical Research Improvement Network, DACRIN. And he's here today to talk to us all about Australia's embrace of prescribed medicinal cannabis, findings from the Cannabis As Medicine surveys. So I'll hand you over to Llew now. Thanks very much for that. Well, what we'll do is, as we're going through, if you log your questions in, we'll collate those and we'll put them to Llew at the end of the presentation.
So my name's Llew Mills. I'm with the specialty of addiction medicine. I'm going to present findings from the Cannabis As Medicine surveys, which we've conducted every 2 years at the University of Sydney. So this is the CAMS team: Nick Linceris, my boss, Ian McGregor, Jonathan Arnold, Anastasia Surev, Thomas Arkell, Dave Alsop, who sadly passed a few years ago, Sarah Abelev, and Silla Zhu. So just as a background, before therapeutic goods can be legally supplied, imported or exported to Australia, they must be included in the Australian Register of Therapeutic Goods. Products not included in the ARTG are referred to as unapproved therapeutic goods. And since 1989, if conditions are met, medical practitioners can prescribe unapproved therapeutic goods that are not on the ARTG under the Special Access Scheme. And this is where a doctor will apply for permission to prescribe something, that a drug that's not, or a medication or a treatment that's not on the ARTG, on behalf of an individual patient. So those approvals are tied to the patient. And that's, we call them SAS. So that's SAS A for patients who are seriously ill and SAS B for everyone else. There's also the authorised prescriber scheme where doctors, and that's tied to the doctor, the approvals are tied to the doctor. So that's where they get a licence to prescribe to multiple patients. And they're quite different. I mean, they have the same results, but they result in quite different data. So prior to November 2016, Australians could be prescribed medicinal cannabis products, but these had to be imported, and it was a very difficult process for clinicians to get approval to do that, to get it into the country. However, in 2016, Federal Parliament promulgated the Narcotic Drugs Amendment Act, and that allowed Australian manufacturers to produce medical cannabis, which made it much easier for people within Australia and the clinicians in Australia to get access to medical cannabis through special access or authorised prescriber schemes. So that's the background. The Cannabis Medicine surveys were created by my boss Nick and Ian McGregor and David Alsop at the Langton Institute, which is a medical cannabis research institute. And it was created to track the changing profiles and experiences of medical cannabis users after post-legalisation. There have been 4 now. They come out every 2 years. There was one in 2016, only a couple of months after legalisation, and then 2018, 2020, and 2022. We haven't done one in 2024. We're going to look at what has changed across today. We're going to look at what has changed across the surveys as kind of a snapshot of what's been changing in the medical cannabis landscape in Australia at large. So the aim of the CAM surveys was to examine consumer experiences of medical cannabis use over time. It's an anonymous and confidential survey that's administered online via the Red Cat platform. So there's no, users don't give us any information about themselves, and that helps because we ask about illicit medical cannabis use as well as normal medical cannabis use. So that's illegal behaviour, so it helps to have an anonymous survey because then people feel they can be honest. It's for Australian residents who had used cannabis for medical reasons in the past year, and they had to be over 18 or over. Recruitment was through online media platforms like Facebook and Twitter, medical cannabis consumer groups, and also the Land Initiative website, and also cannabis clinics via flyers and I guess circulars to their clients. In CAMS 16, we had about 1,700 participants, CAMS 18 about 1,400, and CAMS 20 1,600. So they're pretty decent numbers, and we published papers on each of those. CAMS 22 though, we got a whopping about 4,500 valid responses. So that was very nice. Now, I'm showing you this slide to show you a problem with these surveys. Because it's a convenience sample and we recruitment changes over time. So basically the issue is that the changes that we've observed over time could be due to time and what's going on outside in Australia. But it could also be due to the fact that our recruitment, where we get our participants from, changes from year to year based on the sort of idiosyncratic rules of the social media providers. So you can see that over here in CAMS 16, we got 80% through Facebook. But then in CAMS 18, Facebook suddenly decided that we weren't allowed to mention the word cannabis. And so we didn't advertise very heavily there. So we got most of our participants through Twitter. Now, Twitter has a different profile of users. They tend to be more professional. They have like degrees, which it just influences the makeup of your sample. And then we went back to Facebook again. So that's just something to bear in mind. And I'll refer back to that as we go through. Oh, other I should point out here is like a mixture of these down the bottom, like the Land Initiative websites, referrals through doctors, friends, etc. So the main thing that's changed over the 9 years now, since medical cannabis was legalised, is the prescribed use, which you can see over here on the left. And that's reflected in what happened in our surveys. So we asked people if they had been prescribed medical cannabis at any point in the previous year. In 2016, which was only a couple of months after legalisation, we got, I think, 5 people, so less than 1%. We got about 2% in CAMS 18. That jumped up rapidly in CAMS 20 which was around 2021, to 40, and then we got a whopping over 70% in CAMS 22. And that has had downstream consequences for the data that I'm going to show you. And pretty much as a result, you can see people getting their, as the number of people getting their medical cannabis on prescription has increased, the number of people getting it via dealers, friends and families or growing has decreased. So this is the number of TGA SASB approvals, and that's those approvals that are linked to patients each year, and this comes from the TGA website. And you can see this huge growth, basically. So now in 2024, we had almost 180,000 approvals. In 2025, we're only up to May, and we're already up to 80,000 new approvals. So it's a rapidly growing space. And now we'll start looking at some of the data across the different surveys. So you can see that in CAMS 16, we had virtually no prescribed users. They were all basically self-prescribing illicitly obtained medical cannabis. And because of that, probably, their profiles, they tended to have a greater resemblance to non-medical users in that they were younger. They have a longer history of cannabis use for both medical and non-medical purposes. And they use more non-medical cannabis. I'm going to use the word non-medical cannabis instead of recreational cannabis because I get in terrible trouble from my boss if I use the word recreational, because his argument is, well, are people who are addicted to something using it recreationally? Not really. So I'll use the word non-medical, but you can sub in recreational for that if you feel like it. But over time, the age, and as more people were starting to get their medical cannabis on prescription, you can see the profile of respondents in our survey, and the profile of medical cannabis users generally change over the course of the surveys. Their age increased, and the age they first started using also increased. So they were starting to use later, and that's reflected in this change in the age they first started using went from 35 up to, I mean, it started at 29 in CAMS 16, but then in the later surveys, it increased by 5 years or so. So this suggests, to me at least, that more cannabis naive people were starting to access medical cannabis for their health conditions. And this idea is backed up by these lines. You can see we've got in CAMS 16 and CAMS 18, which have hardly any prescribed users, we've got the proportion who had never ever used cannabis recreationally before using it medically was around 14%. But once we get up to CAMS 20 and CAMS 22, you get a big increase. About a quarter of the people who are using medical cannabis had never used it non-medically before using it medically. And that's also reflected in an increase in the proportion. We asked people, like, what proportion of your total cannabis use is for medical purposes? It's always been pretty high, but it increased as the surveys went on and more people were using prescribed cannabis. So, and down here you can see the cost. It dropped a little bit from 2016 to 2018. But it started increasing again over CAMS 20 and 22. Now, the shift from
We might have a dodgy line up here at the moment. It seems like Llew has frozen again.
Yeah, we might just give it a minute.
Prescribers, if their doctors are reluctant to prescribe, they're reluctant to prescribe flower, and they prescribe it via vaporized or oral routes, which are generally safe. They have less tar. So that's good news. The way people are administering it is getting safer for them. And now some more data on just people's experiences. So we asked people if they had discussed medical cannabis use with their healthcare providers. You can see that has increased over time, suggesting that there's less of a stigma about that as time's gone on. The number of people who said that accessing medical cannabis was easy or straightforward has increased quite dramatically. I mean, it's still not very high, but it's increased. And also I guess as a corollary, the perceived barriers to obtaining medical cannabis have decreased. This one we asked, are your medical practitioners unwilling to prescribe or inquire about prescribing medical cannabis? And you can see that that's dropped as well. The cost as a barrier has pretty much stayed high and remained high. So that's something that people are still unhappy about, is how much it costs to get medical cannabis. Okay, so now what I find the most interesting is the medical conditions that people are treating with medical cannabis. This is based on, we asked people a question basically, what's the main condition that you treat with your medical cannabis? And you can see here that over time, over the surveys, mental health was quite high, and then it started dropping from CAMS 16 to CAMS 22, and then it leapt up again in CAMS 22. And you can see the opposite pattern in pain. Pain and mental health are overwhelmingly the most common reasons that people use medical cannabis. Sleep is a distant third. But this is sort of a zero-sum situation because people could only choose one condition, which was as their main condition. So you can see that as mental health leapt up again from 20 to 22, you get a concomitant reduction from in pain as the main condition. Okay, so just a quick summary of what we've been talking about. So what has changed over the CAMS surveys? Well, the proportion of CAMS respondents accessing medical cannabis legally has increased dramatically from less than 1% in CAMS 2016 to 73% in CAMS 22. The average age respondents first use for any reason has risen, as has the proportion who had never used cannabis before using it medicinally. Respondents are smoking less, they're using oral forms more, and they're discussing the use with their healthcare providers. There's been actually little change in ratings of effectiveness or side effects of medication, and cost is still a barrier to many people accessing prescribed medical cannabis. From CAMS 16 to CAMS 20, the proportion of respondents who mainly use medical cannabis to treat a pain condition was rising and anxiety decreasing. However, that appears to have reversed again from CAMS 20 to CAMS 22. Now, as I mentioned before, CAMS is a convenience sample, so it's self-selected. We didn't do that thing that epidemiologists do, where you make sure that the people that you are responding to your surveys are representative of the general population. And as a result, the changes that we've observed could be due to a different makeup of the cohort rather than evidence of a real trend out in the community. So the question is, how do you know? Well, what you do is you go looking around at other sources of evidence. And this is from a study done by Sarah McPhail and the people over at the Lambert Institute. And what they've shown is that pretty much, especially from 20 to 22, there's been a trend for younger males and females getting approvals for flower products. That's they're smoking cannabis for indications like for mental health, basically, and behavioural disorders. And this is a little bit concerning. And here's another study by another paper in Cannabis written by Martin Lane, which is showing that flower is being increasingly prescribed for anxiety. And that's despite a lack of empirical evidence showing that cannabis is effective for anxiety. So if you look back, you can see, if you break it down by age group, you can see that what these articles were talking about is reflected in our CAMS data as well. So we've got basically, what it looks like is that the relatively youthful cohort of pretty much entirely illicit medical cannabis users in CAMS 16 was diluted as older people started getting prescription. But then as of CAMS 22, younger people seem to be embracing prescribed cannabis more. Unfortunately, there weren't enough respondents in CAMS 20 using prescribed medical cannabis to be able to assess changes in the age makeup of prescribed users. But what we can do is look at special access scheme data, which collects age and the condition for which a prescription was made. And here's that data now. This is all publicly available as data cubes on the TGA website, and I've made these graphs from that. So prescriptions for all conditions increased enormously, especially between 2019 and 2020. And then you can just see that they've just continued to go up. And this is the number of conditions. This is the number of approvals each year. So between 2019 and 2020, prescriptions for insomnia went up by 500%. Anxiety went up 300%. And that you compare that with prescriptions for chronic pain and prescriptions generally, which were around 100%. And you can see it flattens out around 2022, but if you then look at the overall numbers, you can see that they're still very high and staying high. So to really get an idea of this data, you basically need to look at the raw data, and then you need to look at the change data. And I've left out 2018 to 2019 data here because it went from very low numbers to not that high, but it was still a 1000% change, and that just simply wouldn't fit on this graph down. And then if we look at approvals for different conditions by age, you can see that 2019 to 2020 saw the largest increase, percentage increase in approvals. And that the growth in approvals for anxiety was highest among all age groups, but it was especially highest among younger patients. And the increase in anxiety approvals is much larger than the increase. So you can see here, these increases are much larger than these increases for pain over here. And that's across all age groups as well. So the question is then, why are we seeing such a big increase in incidence of anxiety disorders or prescriptions for anxiety disorders among younger adults and adults generally, actually? Is it because there has been a huge increase in the incidence of anxiety disorders in the population? And I would say that this is pretty unlikely. I mean, there's no real reason why it would increase so dramatically. What is more plausible, to me at least, is that there was a hidden population of anxiety sufferers who've become aware that they can now obtain medical cannabis on prescription for anxiety, and thus they're no longer hidden. They're coming out into the open. And this is concerning because, as I mentioned before, and as those articles I cited mentioned, there's actually not very much empirical evidence from well-designed trials indicating that cannabis is effective either for mental health or for sleep conditions. There's just really not any evidence at all. So in addition, there appears to be a culture developing among medical cannabis prescribers where it's considered normal to prescribe for anxiety and sleep disorders despite there being no empirical evidence. So that's a concern. The third, I think, also plausible possibility for the dramatic increase in prescriptions for anxiety is that there are people out there who are basically faking. I don't like to use the word faking, but it's what it is. Who are basically telling prescribers that they've got an anxiety disorder in order to get prescribed cannabis to use for non-medical or recreational purposes. This sort of has parallels. Not obviously, the Australian market is very different to America, but it has parallels to California prior to the legalization of recreational non-medical cannabis use, where people would basically, because there was very little oversight, people could go and get cannabis for recreational purposes on prescription just by saying they had an eye infection or that they've got an anxiety disorder. Anxiety disorders make it easier to get a prescription. They're one of the most plausible ways to get it because, for one, it's quite clear now that people are aware that they can get prescriptions for this reason, and two, it's very hard to check. It's concerning because there seems to be evidence that, at least in the last couple of years, a lot more people are being prescribed cannabis to treat conditions for which there's very little evidence for efficacy, like mental health and sleep disorders. And this begs the question that, are we moving towards the pre-legalization model in California, where you've got de facto non-medical use under the guise of medicinal? And that's been enabled by an increasingly unscrupulous medical cannabis industry who are not doing enough background work for their clients. And I'll discuss that a bit more as we go on. Now, it's worth discussing that the majority of prescribing now occurs via the authorised prescriber scheme. The problem with that is that the authorised prescriber scheme is much more opaque. There's no information about patient demographics or the conditions for which they're prescribed. And there was 67,000 approvals as of 9 AM on 28th of April. So this, as I said, is tied to the doctors, so they can do as many prescriptions as they like once they get an approval, and which makes makes it hard to know what's going on via this scheme. That's why I refer so much to the SAS data. So what went on between 2018 and 2020? Well, can anyone think? Well, there was a pandemic. So that was a small thing that happened. However, the big increase in prescriptions started happening before the pandemic. So what was it? Well, this is what I think it was, and what other people think it was. It was the entry of the commercial sector into the medicinal cannabis space. Commercial cannabis clinics, they greatly streamline the process of obtaining an approval. They basically do all that. They've done all the admin work and all the infrastructure work to make that a much more streamlined process. So it's much easier now to get an approval. Now, we did look at data we did basically ask people who they got their prescriptions from, and we split respondents into people who got them from a GP in a general sort of health setting versus people who got them from a cannabis clinic. And here's some of the data from that. And this is just from CAMS 2022. We didn't really ask these questions in CAMS 20. You can see they have a different profile. The people who get them from cannabis clinics have a different profile generally from the people who get them from general health settings. They tend to be more employed. They were less likely to have never used cannabis recreationally before they started using it medically. So in the cannabis clinics, there's a higher population of people who are using non-medically. People in the cannabis clinics are more likely to meet criteria for both mild and moderate or severe cannabis use disorder. They're less likely to have only use for medical reasons. They're more likely to be getting a prescription for a mental health condition, and they're less likely to be getting it for a pain condition. And this is probably the most damning in a way, is that the cannabis clinics, they're far less likely to treat any other health issues other than the ones that people are coming in for. So they get much less, cannabis clinics offer much less holistic care than in a general health setting, is the message of that slide. This is a table, and I really hate tables, so I have summarised the data here. Cannabis clients are younger. They tend to be healthier. They've got higher scores on the PROMIS 10 mental health and physical health scale. They start using younger for medical reasons, and they use more non-medical cannabis. They also pay more. It costs them more. However, both samples started using non-medically around about the same time. So they started using recreationally around the same time in their life. And they consume cannabis both medically and non-medically with the same frequency. This is the satisfaction data. So participants, so basically you can see here, very satisfied, satisfied, neutral, dissatisfied, very dissatisfied. So participants who are getting medical cannabis from GPs tended to be more satisfied with their treatment overall than people going to cannabis clinics. They get more information about harms and the evidence of efficacy of medical cannabis for the conditions for which they're seeking the prescription. They tend to get more face time, or they rate their satisfaction anyway with of getting the amount of face time that they get. And especially notable is the fact that GPs tend to consider the alternatives to medical cannabis for treating the condition that the patient comes in for than the cannabis clinics do. But it's also worth noting that levels of satisfaction are very high across both general health and cannabis clinics, except fees down here. No one's happy about the fees. However, I will say that satisfaction might not be the best metric for assessing the quality of patient care in this case. If people get what they want, they're often satisfied. But that's not always synonymous with what is good for them, although it is in many cases. And you do have to measure satisfaction, but it's a tricky area, patient satisfaction. So cannabis clinics have streamlined what was a very cumbersome process for accessing medical cannabis and have made it easier for people who benefit from cannabis medication to access it. It's led to people consuming their medical cannabis more safely and getting medical advice on how best to administer their medication. Although it is worth pointing out, as Olivia Dobson did in her article, that it's actually quite unusual. This model is quite unusual. It's unusual for medical practices to be based around a drug. Most are based around a condition or a bodily symptom, like, oncologists, for example, or OBGYN. So that's based around a body condition or a bodily system. They're very rarely based around a drug. There are, for example, there's no anticoagulant clinics, there's no opioid clinics, there's no benzo clinics. But medical cannabis appears to be the exception here. Now, this creates conditions that might, in fact, lead to conflicts of interest. So there's an incentive for doctors working in these clinics to prescribe. And in fact, that is their model of their business model, to get out as many prescriptions as possible. And that creates issues. So what's the answer? Do we just get rid of the clinics? Well, of course not. There's a lot of danger in assuming that cannabis helps no one with their mental health conditions, despite the absence of empirical evidence. Absence of evidence, I would say, is not evidence of absence. Cannabis may help some people with their mental health and sleep conditions. And in fact, 97% of all CAMS respondents say it's effective at treating their condition. And that includes the very high numbers of people who use it for mental health and sleep conditions. So we've got almost all of the respondents saying it's effective, despite there being no empirical evidence for efficacy. So there's a big gap here between the evidence and the anecdote. Now, are all these people wrong? It seems unlikely to me. The issue is, though, is that sleep problems and anxiety problems, it might not be evident. People aren't scientists about their medical conditions. They know what they think, and they of course have to be trusted when they report what they're feeling, but their knowledge of causation is not always great. And that's why we run clinical trials, and that's why we do science. The problem is that if you've been using medical cannabis and then you stop and you feel anxiety after you stop, to the individual, that might seem like, well, oh, medical cannabis helps with my anxiety because when I stop, I feel anxious. The issue, though, is that if you've been using cannabis a lot, you're addicted to it. And if you stop, you go into withdrawal. And one of the primary withdrawal symptoms across all drugs of dependence is anxiety. So how do you know if then you're treating anxiety or if you're treating a withdrawal symptom? Obviously, though, as I said, it's important not to dismiss the patient's experience. They know what they're feeling. So the absence of evidence for efficacy of mental health, of cannabis for mental health, should still give doctors pause before prescribing cannabis. And that's especially to patients who they don't know well, who have had a prior history of non-medical cannabis use, and who have not tried alternative medications that do have a strong evidence base. In other words, much more empirical scientific research is needed into who medical cannabis helps and who it doesn't, and why. And the why question is something that applied research is not great at asking. We're good at asking, does it work? We very rarely ask why it works. And there's also a danger, as a counterpoint, there's a danger in assuming that all people are faking their disorders to get weed. Almost certainly there's some are. I've talked to many of them, and maybe even many, but many are not. And it's also an issue is that it's not always clear to people the boundaries. So there's also quite the demarcation between using medical cannabis for relaxation versus using it to reduce one's anxiety is not always clear, even to the individual. And basically what I think is that we should just legalise non-medical cannabis use. Maybe my haranguing the cannabis clinics might lead you to think that I'm against medical cannabis. I'm definitely not. I just think we should just legalise it for non-medical use. I think that would make everything much neater, and it would definitely clean up the medical cannabis research space, because all these people who were getting prescriptions for anxiety or mental health or other conditions that they don't have, so that they can use it non-medically, would leave that space, and it would be just left with the people who are using it medically. So here's some unintended consequences. This is from an article that I found when I was looking for images for these slides. There's reports that cannabis offences have fallen as the medicinal cannabis sector has grown. So is this because people are using non-medically can now source their non-medical cannabis on prescription by faking an anxiety disorder or some other disorder? Or is it because people who used to source their medical cannabis illicitly no longer need to, and therefore neither group is now exposed to the criminal justice system? Either way, I'd argue that reduced cannabis offences is a net good for the world. And basically, the need for people to lie in order to get legal cannabis would be removed if we simply legalised non-medical use. So as it pertains to the gap between the patient ratings of efficacy and evidence, clinicians will tell you that you must trust the patient, and that is certainly true. However, I would say that there's a reason that doctors don't just turn the prescription pad over to their clients. The doctors are the ones who protect the patient, and they protect them from charlatans and mountebanks, and ultimately they protect them from themselves. Doctors interpret the evidence, and they make judgments on what is good for the patients. So the harm minimisation argument for medical cannabis goes that irrespective of evidence for efficacy, prescribing cannabis to people who would have used it to treat the medical conditions anyway is good, because it exposes them to medical advice, which means safer administration and dosing. It means they'll use it in safer forms, that is fewer contaminants, less smoking, using it by less harmful means. However, I would say this is only true if the doctors who do it are prescribing it in a responsible way. That is, that they're doing a thorough medical history, they're inquiring whether patients have a history of non-medical use, and they're pursuing alternative medications or treatments first if those alternative medications treatments have better empirical evidence for efficacy. And if they do all those three things, then I think that those are conditions then where it's ethical to prescribe medical cannabis. The problem is, though, is that the cannabis clinic's model makes it less likely that doctors do this. And I have heard from many people anecdotally that it's quite easy to get a medical cannabis prescription via telehealth with a 5-minute interview. And I would argue that that's not ethical. That's not ethical prescribing. I'm not saying all medical cannabis clinics do it. I'm not saying all doctors who work at medical cannabis clinics do this, but there does seem to be a trend where this is happening. And thank you very much.
Wow. Very, very informative, Lou. Really some really interesting data, some interesting questions. What I'm going to do first, though, is if we could, can you back up? There was you did pause at two stages. We got you on the third one, but
yeah, sorry about that.
And it was all right. It was only for, and it always, you seem to time it just right. When I clicked myself on, you would start talking again. So I don't know whether maybe it was me. But look, it was the one about the types. There was one there where you got to the type prescribed.
Right.
There was one, and people have asked
for the condition
all the way back. It was in this. It was in the same format.
Yeah, this the one.
That's no. Is there one before that was type? No. Oh, we got that one.
That's.
I think it was, if we went to the smoking one where we had the administration. I think that might be the one.
Yeah, this one here. That
one there. If there was some around that.
Did you see any of this?
We definitely saw it, but you came back online there. So maybe it's that crossover there. Even if we just went back to that previous one, and just if you give us that rundown of your synopsis there, would be wonderful.
Sure, yeah. Well, basically what this shows is that over time, the respondents in the CAM surveys were saying that the main way that they consume cannabis is smoking has decreased over time. And that's because I think the main way people are prescribed cannabis is by oils, edibles or vaporizing rather than smoking. So that's generally a good thing, I think, is that people are now getting their medical cannabis via safer routes. And here is just showing that there's been a decrease in stigma, basically. People feel more comfortable discussing their medical cannabis use with their healthcare providers. They've said that accessing it is easier, although still not very high. The barriers have come down. Basically, there are more practitioners who are willing to prescribe, so respondents like that. And the costs, people are still pretty unhappy about the costs.
No, that's great. Thanks, Lou. That covers that little section. The chat's running hot. I would listen. I'd come to the first question. It's probably the elephant in the room. Where's CAMS 24? Are we? Is the data in? Are we looking at?
We are. Well, we're wondering if there's much to be gained by running another one in the same form. So we're thinking about how to do it differently. Like, we probably aren't going to do much with illicit medical cannabis anymore because just the numbers have just shot up so much. It's so much easier to get. Let me just go to this. It's so much easier to get prescriptions now that I think, that you can see the enormous growth in it. So we're probably focused on the prescribed sector.
Mm-hmm.
But yes, I don't know when it will come out. Maybe in the next year or two.
Let's not put any more pressure on you. It's been great. The other one, I mean, Insight, we're a Queensland statewide organisation, and I guess something that we've heard in other presentations was the phenomenon of Queensland's medical applications, or I think, is that something that you've seen?
Yeah, well, like I was actually debating whether or not to put that slide in, given that that you guys are in Queensland. But yeah, Queensland has the greatest number of approvals for SASB, which I think is unusual given that it's not the most populous state. So there's some culture up there where prescribing cannabis is more cool. I guess, or not cool. Cool's not the word. It's more acceptable for doctors to prescribe medical cannabis up in Queensland for some reason. I don't know if that's because the cannabis clinic activity is more pronounced up there. I don't know.
There's certainly room for more research.
Yes.
Okay, so there's a great deal of questions. Some of them very specific, and I don't know how you're going to go, Lou, with this, but around a lot of the prescribing in the clinics and talking about things like pregnancy, that people in the industry are having people coming in who are pregnant and saying, is this even part of the assessment that's going on? Is that something that you've come across?
Hope so. But I do know that I'm not the only one who's concerned about the how easy it is to get and how perfunctory the workup that doctors do at these cannabis clinics. I mean, the fact that you can get a prescription for a pretty addictive drug that can be, as you say, damaging to the fetus with a 5-minute telehealth interview, that's a bit concerning.
And that answers a couple of the other ones around phone calls.
Yeah.
The idea that we're doing these consults on phones is far from ideal.
Yeah.
Someone said that idea is could cannabis related offences also be just dropping because the police are less likely to prosecute as many people are now prescribed?
Well, I mean, they can't prosecute someone who's got a prescription, right? So.
I was very interested in your harm minimisation, that idea of harm minimisation, that there's all these other parts that sit very well for people in reducing the harms around this. I'm going to keep asking the questions, Lou. It looks like you've frozen just for a minute. Someone's, no, you're back again. The the hyperemesis syndrome. Is there anything about that? Any data coming in around that? Is that something that
we did? I think there were a few, but it's not very common. But sorry, I don't have that data on tip of my tongue or at my fingertips. But we do. There were some people who reported that.
And people in the industry similarly also just saying that there's a lot of people coming in trying to get off medicinal cannabis, reduce it.
Yeah, well, see, it's a complicated space because we here, my boss Nick he's a doctor, and we are researching the use of cannabis to get off cannabis. I mean, it's the same model as for methadone, right? You use methadone as a substitute for heroin to help you get your life together, and then you reduce it under medical supervision. So I don't think there's anything wrong with that.
A lot of telehealth providers in Queensland, someone's suggesting that might be the reason we have many that are being shipped interstate, perhaps.
Yeah.
Limited research. Who are the best researchers to follow in this space? I think we'd just make sure your name's up there, Lou. I think you're doing very well.
Yep. Well, we're doing a fair bit in this area. Anything by Nick Lynn-Serris, my boss, or me, Ian McGregor and Jonathan Arnold over at the Lambert Initiative. They've done heaps of research. So yes, there's those people. But it's a pretty well studied space. So.
Sorry, mate. They just keep coming. That idea around THC and CBD and the ratios that earlier on there was more CBD dominant products, and that now we're seeing a rise in much stronger THC products. Is there any data coming around that, or anything you could comment around that sort of change?
I know we haven't really tracked changes in that, but yeah, I mean we get the CBD only, but we get the CBD mixed with THC. But I think the worrying thing, as I showed these articles, they're saying that there's been a big increase in prescriptions of flower, which has very high THC. People are smoking it, obviously, which makes me think that there's a lot of faking going on out there, really. I mean, I'm not saying it's all that way. As I said, you have to couch this in very cautious terms. There are people that legitimately are helped with cannabis, but I think there actually is probably a lot of people who are misrepresenting what they're having a medical condition in order to get it. And those people want to get potent weed, basically.
Yes, and overseas experiences suggest this is part of the pathway towards what you were indicating before about that.
I mean, humans, if they can see a way to do it in a way that they like, will do it. I mean, like I said, I would do the same thing. Honestly, when I was younger and smoking lots of weed, I would have done exactly the same thing. You can't blame people for doing that. You can't blame people for being human. What you can do is try and put up some guardrails, and that's just by having a little bit better oversight, doing better patient histories, just giving more holistic care. And at the moment, the cannabis clinic model is not conducive to that.
Lou, I couldn't think of a better way to finish this up. That's a wonderful note to end on. Listen, thank you very much for coming in today and sharing some of this research. We look forward to seeing as it comes and the other stuff that you're working on at the moment. I think it's a great way to get back on track with the webinar series. Thanks again, Lou, and I'll leave you all and hopefully see you all back next Wednesday, and we'll continue the webinar series.
Thank you, everyone.
A lot of real positive thanks and real congratulations. Great presentation. Thank you. A resounding great presentation, Lou. Thanks for sharing.
Thanks for inviting me.